Aren't you itchy all the time?
All the time. They get used to it. Okay, you're live on TikTok. You're live on Facebook. And you are live on Instagram. Everything works today, obviously.
Welcome to the show, everybody. I'm sure you're all logging on. So we'll give you all a minute to jump on, and then we'll know what's going on. And I guess we've got sound.
Got everything. Oh, can you pass me my phone?
I can pass. Yep.
Just unplug it. Yeah. So he's diving for it.
Okay, welcome to Fertility Fact or Fiction, the Saturday edition.
The Saturday edition.
Yeah,
That's right.
Yeah, kind of the Euro edition. I mean, it's
We
really
should have just said that. That's right.
people could watch in Europe. I'm your host, Dr. Rahi Victory. I am a double board certified reproductive endocrinology and infertility specialist, licensed currently in 2 countries, hopefully very soon 3. We have 4 clinics now and are growing very rapidly. And we believe in a different model of care. So we really try hard to look at root causes. We want to give people answers. We want to figure out what's wrong, and then we want to help them get to their goal of whatever number of babies they want. So I am here with my dear friend Tariq Ibrahim from Ibrahim Strategies Group, and we didn't get a chance to take too many questions last time because we had the amazing ladies from Mystoria on, and so we promised to do a side gig show. So here we are, and we are going to take questions tonight, and I think we still have lots of leftover questions from last week as well. Did we record all of those questions? I don't know if we did or not.
We did.
But you don't know where they are right now.
That's right.
Well, we have the previous questions too. We could always answer if people. In the fertility world, exciting stuff that's coming around the corner. We will be ready to do our no medication, immature egg collection, IVF cycles very, very soon. I am hoping December, but definitely by January for sure. Once the media arrives, we will be good to go. And so I'm excited about that. Are we having audio issues or are we good? No, everything's good. So that's going to be exciting. It'll be dirt cheap, so very inexpensive for IVF. It'll be potentially very useful for older women. That's what we're hoping for. So we're going to start it kind of as a research effort to see what the results are, or at least we'll be studying the results as part of a research project. And then if it works, it'll be a game changer. Also, we're going to be starting research on a product that can be used with immature eggs that apparently solves the problem of aneuploidy. So if we retrieve these immature eggs in older women in particular, and we use this new product and we can mature the eggs well, which we've mastered pretty much now, we are very, very hopeful that we will be able to literally revolutionize fertility care. And keep in mind, this involves 0 medications. So we're very excited about that. That should be really cool. And many of you have heard me kind of mention it in passing, but it was kind of top secret until now, but it will be available soon. They're just creating the package for us, and I got to do the consent forms tonight or tomorrow, and then we'll be up and running. So super excited about that. That'll be really cool. And not a whole lot else. We've got some interesting material coming up for videos on dental hygiene in relation to fertility.
That's Monday.
Is it? Mm-hmm. We're going to have one on endometriosis coming up soon as well. We've got a bunch of stuff coming. So there's going to be some cool things out there very soon. And we're going to do one on diet and nutrition, in particular for men, in relation to sperm health. So that'll be a whole male video that we can look at. Yeah, that's pretty much it. Not a lot else that's going on. I did have consults all day today, and I actually had probably one of the craziest fertility journeys I've ever heard from somebody today. So I am very passionate about helping that couple out because they definitely deserve some extra TLC. So if you do watch the show, you know who you are. I'm gonna figure out a way to make this work for you. I'm sorry you had such a rough go so far. and we'll find a way. We always do. Okay, do we have people logging on?
Yep.
Questions already?
Yep.
All right, fire away.
So my estradiol before stims was 500. It was high, but decided to proceed anyway. Is this doomed to failure?
No, I mean, the problem with having a high estradiol is you may have an egg that's further advanced than you want it to be. And if that's the case, then you'll have either premature ovulation or premature follicle growth. And the problem with that is you're going to have an asynchronous cohort. So you may have one egg that's ready after 5 or 6 days, and then all the other ones are lagging behind. So it can cause problems, but in this day and age, we know how to deal with that because you either retrieve the one early and then continue letting the others grow, or you just sacrifice that one and you go for the other one. So there are ways around that. It's definitely not doomed.
Follicles with 7.5 milligram, one with 10 milligrams, and ovulated early.
Is that the question?
It appears that's the first part of the question. I don't know if the rest came out. We'll go to another question. That's all I got on that one.
So 7.5 and 10 milligrams and ovulated early?
Yeah.
I need more to that question.
Can immature eggs be the cause of recurring miscarriage?
That's a great question. I don't know. I mean, you wouldn't normally fertilize immature eggs, so unlikely. But if there was an egg quality or an enzymatic issue, then yes, that's possible.
I'm just trying to find that because the question's here. Can somebody still get pregnant naturally, 2 ectopics and a chemical, 4 IVFs with 0 blasts? And this person also has the same person is the 2 follicles with 7.5 milligrams, 1 with 10 milligrams, and ovulated early.
I mean, can you? Yes. Are you likely to? Not with the history you're giving me, so I would need to know more detail about you to figure out what went wrong. I mean, we see people every day who didn't get the right priming or got birth control when they have weak ovaries, which makes no sense, or have endo and didn't have an endo protocol, or didn't have appropriate pre-treatment, supplements, natural things, diet, exercise. Like, there's all sorts of things that can be done to tweak success. And we try and do that every time. So, yeah, we need to know about that. I apologize for looking very scruffy, by the way. Sorry about that. I have been doing my best with my very sparse beard to cover up the massive facial bruise I had from running headfirst into one of those parking lot wigwam, I think they call them. And so it's starting to fade, so I'll be able to shave again soon. Yeah.
My second period after egg collection, planning for frozen transfer, is 8 days late. I'm usually very regular with a 28-day cycle. When should I be concerned?
I mean, I'd go get checked out, make sure you're not pregnant. If you had sex around the time of your egg retrieval, you could be pregnant. So there's enough reason to go get checked out. You should be literally on the dot 14 days after your egg retrieval, so find out why you're not.
Do you think acupuncture is a make or break for a successful transfer?
No. Nothing is a make or break, maybe other than progesterone. So there is nothing that's a make or break for a successful transfer. Acupuncture definitely isn't. It's actually quite controversial. There are studies that show benefit, there are studies that show no benefit. Overall, we feel that if it helps to relax you, it's likely beneficial. But we know for sure that there's no 100% clear-cut data for this saying it's absolutely beneficial. There are people that believe it's helpful, but it's not there all the time. Yeah.
What does it mean when a thawed embryo doesn't expand before it's transferred?
It just means it's being lazy. Now, it doesn't mean it won't work, but the chances are lower. So you want the embryo to expand before you transfer, ideally, but we still transfer the non-expanded ones because they can expand in their natural environment. Oh, hold on.
Can immature eggs be the cause of reoccurring
You
miscarriage?
asked
I
me
just-
that,
okay.
yeah.
My second period after that, can somebody say, that, what? I wasn't even looking on my phone to read them. Okay. Can somebody still get pregnant naturally? Oh, yeah, naturally, 2 ectopics, 1 chemical,
Yeah,
4
we
IVF,
did that
yeah.
one.
I've had 2 chemical pregnancies using high-grade donor embryos.
Oh.
What could be the cause if it's not the embryos? I have adenomyosis and downregulated for 2 months with Prostat.
So, could be infectious, could be immunological, could be a problem with egg quality or sperm quality. Could be you, shape of your uterus, volume of your uterus, vitamins, thyroid, body mass index, habits, smoking, drinking, drug use. I would need to know you to be able to answer that. But it is unusual to either fail or miscarry with donor egg embryos unless something is amiss. So that's something where we usually tell you to reach out to us and we'll help figure it out, because normally I can figure out what's wrong, whether it's from testing or just your history. I had a couple today I spoke to where we realized that there had been kind of an error in their cycle where she had clearly ovulated and no one had told her that. So, things like that come up. When we had the ladies from my story on, same story. I mean, she had a lady that had ovulated and she told her, and so that lady got basically a free cycle with her meds comped. So I think that, sometimes we can explore things and find ways to help people regardless of where they're doing their fertility care. So I'd need to know the details of your history to help you out.
When do you think St. Catherine's site will be available for IVF satellite monitoring? Also probably not anytime in the near future.
Now.
Now?
Yeah, it's ready.
Oh.
We just got our second ultrasound tech there too, so yeah, it's ready now. You can get monitored. We just have a hard time with the bloods because the lab machine will be installed in January, but after January there won't be any problems. We can do everything on site. Right now we send out the bloods.
I'm younger with a low AMH.
Okay.
My body didn't like the drugs too much. Would I be eligible for the new treatment in January?
Yes. Yeah, you would be. Yeah.
With the immature egg question being linked to miscarriages, I mean if you're conceiving naturally and ovulating immature eggs.
So immature eggs won't fertilize. Like if we take a sperm and we stick it in an immature egg, it won't necessarily fertilize. So you can't ovulate first of all, you shouldn't be able to ovulate an immature egg, but even if you could, it won't fertilize at all. So it's not going to cause a miscarriage.
What success have you had with letrozole flare protocol?
So we tried letrozole as part of our STIM protocols. We did it with a Lupron microdose flare, we did it without, we did it with antagonist. It was bad enough that we stopped. Now I am tempted to start again because there are some studies that are suggesting we should go back to it, but there were also studies saying stop it. So I'm kind of confused on the letrozole message. I don't know if it's good or bad. I'm kind of tempted to try it again, but you do have to go 1 extra day past where you normally would in order to get the eggs to be more mature. And that means a whole extra day of meds, more cost, a longer stim. So it's not necessarily ideal, at least not for everybody.
What does it mean when morphology is 4%, but DNA fragmentation is only 6.8%?
So 4% is normal, and that's a normal DNA frag, so it means you're normal. 6.8? Those are both normal.
If one has severe diffuse adeno, would you advise surrogacy? If so, what are the things to look out for when going into surrogacy?
Oh boy, not necessarily. It would depend on how many embryos you had. We always want to try and get our patients pregnant themselves for many reasons, not the least of which is enormous costs associated with surrogacy. So I would definitely try to help you. So we would run our endo protocol on you if you had enough embryos or wanted to just try naturally and see if that was of benefit to you, because we've helped many patients with that. But having said that, if you were miscarrying, recurrent implantation failure, that kind of thing, then yes, we would talk about surrogacy. What's important? So the agency is critical. You want to work with people you feel comfortable with, people that you trust. What else is important? Costs. I mean, different agencies have different costs. Some agencies charge you upfront just to get in the agency. Other ones charge you when you match. So you got to consider which one you want to be bound to. And then you need to go with an agency that can provide you a surrogate within a reasonable period of time. And I strongly encourage you to look up the reputation of your agency online before you sign up. Some agencies have impeccable, reputations and function, and others don't. So before you make a choice, go online, read what other people's experiences are, reach out to our third-party team and ask. Go on our website, see who's good, who's not there, that kind of thing. So yeah, I mean, we have some we recommend. And it changes from time to time. We're going to take off one of our egg donation companies. Stuff changes as we go through it, but keep an eye on stuff like that. All of that's really important. And then of course the surrogate herself, healthy, normal BMI, not more than 6 deliveries, not more than 3 cesarean sections in most cases. No smoking, no drinking, no drug use. You don't want someone that's on 10 different psychological meds, like someone healthy, happy, stable.
I had a lap and the doc said it looks globular, but adeno doesn't show up on MRI, one failed transfer.
Wow, I'd have to see your MR and your ultrasound. Globular by itself is probably not enough to make a diagnosis, so I'd have to see what your uterus looks like.
Hi, Dr. Victory. Can you tell me what is the cause of asynchronosis follicle growth? Asynchronous follicle growth during controlled ovarian stimulation, and how to solve it?
So you can try priming. So that's what some people use estrogen priming for. I'm not a believer in it because it's never been shown to be beneficial for women with diminished ovarian reserve, but it can help with synchrony. So what causes it? It's just usually common in older women where their FSH levels are higher, so they're actually recruiting the follicles earlier. And so it throws the cycle off from where you would think it should be. So those cases you have to either suppress with birth control, which I hate doing, or you have to use estrogen priming to line them up. Some people are now using cetrotide priming. We find if we use human growth hormone, DHEA, and testosterone, we pretty much eliminate that problem. The other thing, which does pose some financial issues, but is very good, is don't try to synchronize. Just collect one cohort when they're ready, and then keep stimming afterwards and collect the second cohort later, which is like a duo-stim approach. So there's different ways to do it. I don't know how you live with the beard. Like, I'm like furiously itchy.
You get used to it.
Really?
Oh yeah.
I can't.
You get used to it
like
for
this,
sure.
I cannot wait to shave this.
Oh no, you get used to it.
It's killing me. Plus, it doesn't look right on me. See, you got a fuller.
You have to, you gotta give it some time. Give it a week.
I'll never be you. Like, that's not happening, man. Yeah. I look like a white guy.
You look good, man. You look good. What are the reasons for recurrent miscarriages?
So hormones, in particular thyroid problems, high thyroid antibodies, Hashimoto's, Graves', that kind of thing. Shape of your uterus, fibroids, polyps, uterine septum, bicornuate, all of those have been associated. You can have infectious problems, that's huge. You can have immunological problems, that's a very significant factor. Thrombophilia is thought to be things like lupus, antiphospholipid antibody syndrome, high sperm DNA fragmentation, elevated body mass index, drug use, smoking, alcohol. I'm probably missing a whole host of them. Low vitamin D. So all of these things have been associated with it. Poor egg quality, poor sperm quality. Scarring in the uterus, thin endometrium. It's a pretty good laundry list.
That's a lot of things.
Are there a lot of people? I'm curious for like a Saturday.
And for a Saturday with, there's a good amount. There is a good amount.
Cool. I wasn't sure what we were gonna get.
You got questions. Is
Yep.
2 unassisted miscarriages in late 20s and early 30s most likely just chromosomal issues and will eventually have success? Thank you.
Well, 2 in late 20s, early 30s is unusual. Most likely it is chromosomal, but I'm not gonna say that's common. So I would probably get seen, and nowadays most guidelines suggest you get evaluated after 2 in a row. So it's not uncommon, but I can't say I'd feel that that's super normal either. I'd wanna have investigations and evaluation.
Can being on northestrone,
Northestrone?
northestrone? Sure. Sure.
She sells.
Northestrone.
Yeah,
To bring on menstruation prior to IVF cycle affect good equality?
no, it won't affect that quality.
I'm 42 and have DDOR. Would it be a good idea to take the birth control pill for 10 days and
No.
overlap with Lupron for
No.
3 days
No.
before starting
No.
stimulations?
No, do not take birth control before you start your cycle. It's horrible, especially if you're 42. And overlap with Lupron, that makes no sense. So no, we don't recommend that. Estrogen priming in older women and women with diminished ovarian reserve now has 2 randomized controlled trials, both of which showed no benefit. So there's no value to doing that.
Hi, Dr. Victory. What are your thoughts about segmental embryos?
So segmental aneuploidy has about 40% chance of actually only being a mosaic, and then if it's a high-level mosaic, it would have as high as a 30% chance of becoming a normal baby. If it's a low-level mosaic, it has an extremely high chance of becoming a baby. So we are actually using them now to transfer because it's worth trying. They shouldn't be tossed.
To clarify my question about the late period, I had my withdrawal bleed after egg collection, no problem, but my next one is late. I read this can happen, definitely no way I can be pregnant.
Oh. I'd still go get checked out. Check your thyroid, check your prolactin, check your hormones. Yeah, I would need to know how many eggs you had from before. And if there's absolutely no way you could be pregnant, that's a different story. But if there's even a smidgen of a chance, I can't tell you how many people we've had that did IVF, were waiting to do their frozen embryo transfer and then got pregnant right away after. So make sure you do a preg test regardless. Unless you're not actually having any kind of exposure to sperm.
What should progesterone levels be before transfer?
For an average person, between 40 to 100 nanomoles per liter, or 10 to 30 nanograms per mil. For an endo patient, between 37 to 45 nanograms per mil, or like 130 to 150.
Do you believe in superfertility?
Yes.
Is it a real condition?
Yes. Superfertility is the idea, which is from Nick Macklin, who's this really brilliant, very ancient British fertility specialist. He was just at that conference in Valencia I was at. He actually presented on this again, but I've heard him speak on it many times. So the idea is that some women have the ability for the uterus to just accept any embryo. So whether it's a good embryo or a bad embryo, it doesn't matter, it'll take them all. But then they recurrently miscarry because the embryos actually aren't good embryos. So it's not discriminating the good from the bad, and because there's no discrimination, it just accepts everything. So you start pregnant, but then you don't continue pregnant. And the idea is that these women are the ones that have, 5, 6, 7 recurrent losses all the time. Is that cable like loose?
There's some little glitch every once in a while. I'm trying to figure out where it's coming from. Like in the video, it's like a little blink, sudden
weird.
blink.
Okay.
My OB thinks I should do another embryo transfer, so best results. But I just gave birth in September. Seems soon. Stage 3, 4, 3/4 endo excision March 2023. 3 or 4.
Yeah, that would be insane. Like breastfeed your baby for 6 months first, and then talk about doing an embryo transfer. And as long as you're breastfeeding, your endo is suppressed. So I don't know what your OB is talking about. You definitely should not transfer 2 months after you had a baby. That's maniacal. You're busy. You don't want to be pregnant again. And your baby should get breast milk, ideally, for 6 months. Plus your body needs to recover a bit. So yeah, that's way too fast, in my opinion.
Is a hatching embryo more likely to be chromosomally normal?
No. It's not more likely to be chromosomally normal, but it is more likely to stick. So there are benefits to hatching, but chromosomally normal is not one of the benefits. Not that I'm aware of, although admittedly I've never looked that up before, but not that I'm aware of.
I watched on Netflix Joy and thought about you, Dr. Victory.
Oh yeah, I gotta watch that. Do you know what that is?
No.
You and I gotta watch that together. We could do a commentary.
Oh, that's the thing?
It's the IVF movie.
Oh, really?
On the start of IVF. Yeah.
Oh, yeah, we should
It's the whole
absolutely watch
Louise
that.
Brown.
Maybe that's what we should do.
And then video that.
Yeah. That's a real thing.
We could do it Tuesday before the show.
Yeah, that's
wanna
a
do
double take.
Double
Only
take.
popcorn.
I'll bring popcorn. Yeah, I'll bring it.
Estrates and progesterone before my FET was
No.
stage 4 endo.
No.
28-year-old. Is this a good protocol?
No, of course not. It's horrible. Don't take estrogen before an endometriosis related FET. You're just fueling the endo. That's insane. And you can't take progesterone. So you want Lupron, letrozole. You want a letrozole based cycle. No estrogen if you can avoid it. You want to do high dose progesterone, double, so injectable and vaginal, and then you need a whole bunch of supplements and you need an immune protocol. So we have a dedicated customized endo protocol. I get, people from all over the world every day who say they got a hold of my endo protocol. I don't even know how they got it, although we have it on our YouTube channel. And that after years of infertility, they finally succeeded, and it was because of our protocol. So yeah, don't be doing estrogen. That literally makes 0 sense. None. Zero. Tarek knows that.
Don't do it.
He starts laughing even before he asks the question.
What stimulation protocol would you recommend for 39-year-olds with low AMH and stage 3 endo?
So assuming you're doing a frozen embryo transfer, like a medium dose protocol, you don't need high doses because it's not helpful. I'd probably prime, so DHEA, testosterone, human growth hormone. Lots of supplements, NAC, curcumin, resveratrol, ALA, coenzyme Q10. And then, yeah, we would go ahead and do your retrieval when your eggs are ready. I don't let people go long. Apparently there's a whole group dedicated to one fertility center in Toronto, not the fertility center, but a single fertility center in Toronto, where they routinely go 16 to 22 days of stim. So that's proven to be detrimental. So I don't know that I would ever do that. So you want to definitely retrieve earlier than that. But yeah, I mean, I would aim for like a reasonable time to get the eggs. And then, yeah, do the best you can from the lab standpoint for fertilization and so on. But I'm not a fan, especially in endo patients, of giving them massive doses of meds because they don't respond to it. So it just kind of fries the eggs without doing anything beneficial. Makes the fertility center a lot of money, but that's it. We don't need more money, we need more babies.
Hi, Dr. V&T. I was finally acknowledged. 29 minutes in. Somebody remembered I'm here.
Has it been 29 minutes? Oh my god, yeah.
Yeah. 29 minutes in and nothing. Miracle.
Wow.
What are your thoughts on frozen versus fresh donor sperm? Donor eggs.
Donor eggs
Thoughts
or
on
sperm?
frozen versus fresh donor eggs.
Oh.
Pros and cons of each.
Yeah, there's no question fresh eggs is way better. There's just a study published recently in Fertility and Sterility that confirmed that. The success rates with fresh eggs regardless of a fresh transfer or a frozen transfer, is way, way better. So this is something that we would be strongly in favor of. And we have pursued that. I've looked actually at opening up a frozen egg bank. It's not worth it, at least the way we looked at doing it, and the success rates just aren't the same. So it might be beneficial for a select few people, but it's expensive and you get a way lower success rate. Just quickly with the math, only 70% of the eggs survive the thaw. So right off the hop, you're down 30% from where you would be fresh. Then only 70% of them fertilize. That's reasonable, you know, depending on how good your ICSI program is. Sometimes you get better, sometimes you get worse. And then only about 50% of those will make it to blastocyst, whereas sometimes we're getting as high as 70% or even 100% blastulation. So you're getting a much more significant attrition rate with your frozen eggs than you are with your fresh eggs. So you might start with the same number of eggs, usually you won't, but you're going to end up with less blastocysts at the end of it, no question. And that's the whole game, is how many blastocysts do you get at the end. The other thing is that if you start with more eggs from a fresh than a frozen, which you will almost always, then that's a huge change in the numbers game. So we very rarely recommend frozen eggs. We do in certain circumstances if you're looking for something really unique or special, or eggs from a culture where they're really hard to find fresh eggs from. Yes, of course, consider doing frozen eggs. But aside from that, it doesn't make a lot of sense for the vast majority of people.
So the one regarding the question about, where is it?
I don't know, I can't see it.
Estrogen and progesterone before my FET,
Yeah.
Follow-up comment, I have voiced so many concerns about this, but they keep saying it's okay. Plus did estrogen priming.
Oh, God, yeah, no, don't do that. I don't even know what to say, yeah. It doesn't make sense. To me, it doesn't make sense. I mean, talk to your fertility specialist. Maybe they're smarter than we are or have more experience than we do. I'm not going to say one size fits all, because it doesn't. But it doesn't make any biological sense to give someone with endo any kind of high-dose estrogen. Minimal amounts, maybe. I mean, we have to do that sometimes too. But high doses, no, never.
Is an extremely light 2 or 3 day period concerning?
If it's a change, it could be. As a general rule, it reflects the volume of the uterus and the thickness of the endometrium. So you've got to wonder why it's not a heavier period. Is the lining too thin? Is the structure of the uterus abnormal? Is your blood flow not adequate? So those are all things I would want to know about. I had another patient today, I think, had tuberculosis of her uterus. That's wild. Mm-hmm. It's almost exclusively in our Pakistani and Indian population. We find out they have TB in their uterus, and that's like so hard to treat.
Wow.
So I think I had another one, but we'll see.
To further clarify my previous question, are morphology and DNA fragmentation correlated? It seems strange to me to have excellent DNA fragmentation but barely meet the threshold for normal morphology. Previous morphology has been less than 4%.
So 4% is actually considered normal. So having normal sperm DNA fragmentation, no, you could have normal sperm DNA fragmentation and abnormal morphology. Like, my lab is super strict about the sperm, like super strict. And so very few of our patients actually end up having normal morphology, but lots of our patients are okay for the DNA frag. So they're not intimately linked to one another. You can have normal DNA frag with borderline or even low morphology. Now, if you've got really low morphology, yes, you're probably going to have higher DNA frag. But 4% is normal, so you're probably still okay.
I've been taking DHA for 3 months and my period has stopped, so I can't start my next cycle. Now, having to try Progesterone to bring on menstruation. Have you heard of people losing periods using DHEA?
Well, I guess my question to you would be, if your ovary is weak enough that you need DHEA, are you at risk for menopause, in which case you need to be tested to see if you're becoming menopausal. But typically women don't lose their period just going on DHEA. In fact, I cannot think of a single case we've had where that's happened, so no.
I have 10 fertilized eggs. I'm waiting my 5-day call.
Yeah,
I have had 2 miscarriages. Should I test the embryos? I'm 36, overall healthy.
definitely. No brainer. You've had 2 miscarriages. You want to reduce the chances of miscarriage. You want to know that your embryos are genetically normal. And you're 36, so most people who believe in PGT would recommend it. I know there's lawsuits against PGT companies because apparently they made false claims. I personally don't believe those lawsuits are going to go anywhere, but the data on PGT is terrible. The studies that have been done have demonstrated flaws and complications with them, so that's not helpful. And so the only good data we have is that it shortens the time to pregnancy. There is data demonstrating it reduces miscarriage risks, and we know it makes it cost effective in the US. Not necessarily in Canada where it's much cheaper, but probably even in Canada depending on the number of embryos you have. So I'm a believer for over 35, and we use it liberally in that population. Obviously we give people their options, but I think it works, yeah.
2 euploid embryos at 38. First transfer successful after endo protocol at 39. What are the chances a second transfer will be successful too?
Depends on the quality of the embryo, but if you made them at 38 in our hands, probably about 70-80% if you're using an endo protocol.
Moving to PGTA after 2 losses for unknown reasons and a RPL workup that was all clear. Is that reasonable? I haven't done any immunologic testing yet.
Well, for anyone that's had recurrent pregnancy loss, doing IVF with PGT is not mandatory, but it does fill in a huge knowledge gap, which is, are you making normal embryos, and are you miscarrying normal or abnormal embryos? Because if you're miscarrying an abnormal embryo, that's actually expected. If you're miscarrying a genetically normal embryo, that's a huge problem. So it's a benefit in terms of answering questions. So we would definitely support the use of PGT there. However, you should also be doing a full RPL workup, which in my opinion would include things like a microbiome test and immunological assessment.
What stimulation protocol would you recommend? Last 2 SIM cycles, 75% of the follicles are empty with a double trigger, 40 years old.
Yeah, I don't believe that. So we flush. There's really very few times where your follicles are actually empty. So you have to find out if they flushed. If they flushed and they were empty, okay, I get it. But if they didn't flush, you don't know if your follicles are empty or not. So first of all, find out if they flushed out your follicles. If they did and they're still empty, I would try a triple trigger. And we're going to review that. That's another article coming out that clearly shows that the double trigger is better. So that's something everybody should be doing, and I've been saying it for years, and now there's proof for it, so that's good. And so that would be important. So you can triple trigger, you can get flushing done. It's extremely, extremely rare that follicles are actually empty, there's no egg in there. It's usually a failure to flush the follicle out or for the follicle to release. And there are hormonal things we can assess along the way that kind of help us know if you've released or not.
What's your thoughts on being on SNRI during fertility treatments? I experienced too many side effects on SSRIs.
It's a hard no. Yeah, we don't allow anybody to be on Effexor when they're going through IVF treatment.
I had my placenta studied from 3 of my miscarriages at Yale. Dr. Kilman said my recurrent miscarriages was likely chromosomal. Me and partner both had karyotypes and carrier screening come back fine. That's all I got. I feel like it goes on, but I do not see it.
I mean, you and your partner can be normal, but your embryos can be abnormal. And the older you are, the more common that is. So just because your comprehensive carrier screen or karyotypes were normal does not mean you're not producing genetically abnormal eggs. You very likely are. So that's something that needs to be evaluated. And that's an easy thing to assess with IVF and PGT. That's how you would do it.
What is the best stimulation protocol for DOR and 42-year-old FSH11 high or low stim?
Okay, so there is no best. Let's start with that, right? Every patient is different. Every patient needs to be individualized. So I'm not going to tell you that there's one best. What can I tell you? There's lots of research that shows that high-dose stimulation protocols are detrimental or of no value. So they're expensive, which is detrimental, or they're damaging, which is detrimental, or they're useless, in which case they're expensive, which is detrimental. So any way you look at it, high-dose protocols are not beneficial for people. So a medium dose or a low dose is reasonable in those situations, or depending on what kind of results we get with our upcoming research study, a no dose, like just no meds. Like our protocol is actually going to involve zero medication. You don't take anything. I could meet you today and retrieve you tomorrow, and we'll get eggs out of you. So that's what we're aiming to achieve now. I am stoked.
It's a big deal.
Pumped.
It is a big deal.
Yeah.
What can cause multiple embryos to have chromosomes missing or have too many?
Age, poor sperm quality, aggressive IVF stims, bad egg quality, yeah, all sorts of different problems. Sperm aneuploidy, genetic aneuploidy for the parents.
Retrieved at 33 years old and 4 out of the 9 embryos were euploid. Is that a normal rate for 33?
4 out of 9 embryos at 33? No. That would be low. You'd expect actually 6 at 33 because a third would be abnormal. So 6 should have been normal and 3 should have been, 6 should have been normal and 3 should have been abnormal. Yeah.
What should progesterone levels be before transfer, and what is your immune protocol?
Well, again, it depends on, I can't answer that. It depends on what's wrong, right? So if you're talking a non-endo patient, you can easily do 10 to 30 in US units or 40 to 100 in Canadian units for your progesterone level. Immune protocol depends on what's wrong. We have immune protocols that involve just steroids. We have immune protocols that have sub-QIG, intralipids, steroids, Plaquenil, tacrolimus, lit therapy. I mean, I don't, Neupogen. It depends on what's wrong with you. We don't have a catch-all immune protocol because that doesn't make sense. Once you're delving into the whole immune world, it makes a lot of sense to get testing and figure out what's wrong so that we target the treatment and fix whatever's wrong. You don't want to be just throwing stuff. There's a very large US-based fertility company that is very well known that just takes every single immune treatment and gives it to patients when they fail. And this is their throw spaghetti, although one of my patients today said throw jello at the wall and hope that something sticks. I think that jello is more apt in that approach because jello doesn't stick, so nothing's gonna stick. It's just gonna bounce literally off the wall. But the reality is that there is no evidence for just willy-nilly giving people immune treatments, with the exception of intralipids. Intralipids actually has been shown to be beneficial in untested populations, but for everybody else and everything else, you're actually supposed to test people. You can't eat jello.
There's some jello I can eat. There's some jello I cannot eat.
Is there non-pig gelatin?
There is non-pig gelatin. Oh yeah.
From what, like beef gelatin?
There is beef gelatin and fish gelatin.
Oh really? And do they make like halal jello?
Halal jello.
There's halal jello?
Oddly enough, a lot of Asia,
Yeah.
since they have an abundance of fish, will use fish. It's
Jello.
not even halal, it's just
Fish.
gelatin.
What's in our jello?
North American?
Yeah, it's
predominantly pig.
It's pig. I don't think I've had jello in like 30 something years.
Yeah, maybe. That's Jello for you. It's just all over the place.
I actually really like Jello, and I'm kind of
When I
crazy.
think about it,
I'm kind
I've
of craving
never
some
not
Jell-O.
enjoyed Jello.
Like when I was little, I used
that
to
was-
do I used to make it like the layered one with the different colors.
Oh, you were that guy?
Oh yeah, I was that guy. Yeah, it
That's
was
nice.
good. Yeah, yeah. Now I'm craving.
You
some
put
Jell-O.
bananas in your Jello? You ever do that?
My aunt used to do it, but then it would go rancid quick, right?
Very quick.
Oh, that was not
Soggy
good.
banana. Nobody wants that.
Man, you're bringing back some serious memories there. Yeah, no, that was never good. I did not like the bananas in the Jell-O. They used to put some fruit in there and stuff, but
Kiwi? You ever have kiwi?
I don't think I had kiwi. I had grapes.
Oh, grapes, yeah.
Yeah, like they would be okay.
It's like a fruit salad. That was like the kid-friendly fruit salad.
Yeah. But the bananas always got like mushy around the
So
outside.
gross.
It was not good.
Anytime I saw bananas, I'm like, oh, why'd they ruin it?
Yeah, I did not like. Oh my god, I
Why
forgot.
would you ruin
I
it?
forgot all about fruit in the Jell-O. How many of you remember fruit in the Jell-O? Because if you do, you're probably too old to be watching this show.
You think so? You think fruit
You're gonna need donor egg if you remember that. That's for sure.
I wonder. So like people don't do it anymore? I don't even see people eating Jello
I
anymore.
don't see people eating Jell-O
Right?
anymore.
Is it gone?
When was the last time you had Jell-O?
A while ago.
I cannot remember eating Jell-O. It must be.
I can't even remember seeing Jello.
It's got to be 30-something years since
You
I've
know,
seen
when
it.
I was a kid, we'd even go to the States for a buffet, and Jello was an option.
Remember the little perfect cubes?
Yeah.
And you were like, how did they cube that stuff?
I don't know. No. I think maybe we are too old. This is the sign. If you've had Jello with fruit,
You know what?
You're
I'm gonna
old.
make us some multicolored Jell-O. I'll bring us some Jell-O for next time. I'll find some.
You know what? You should do it and show the people online because they probably don't even know what the hell it is.
I love it.
They don't even know what it is. They don't know what we're even talking
But
about.
do I put fruit in it? Anything
No,
but banana?
anything but
Leave the
banana for
fruit.
sure. Keep that banana for yourself, man. Keep that banana away from me.
Yeah.
Does your clinic discard poor quality blastocysts?
Yes. With your permission, but yes. Yeah. We don't keep them if they're 3 cc or less. Sometimes we'll keep the 3 cc's, but generally speaking, 3 cc or less we don't keep.
I had fruit in Jello and I'm 27 years old. Here we go. This is the hero.
Really?
This guy's Cam. Cam's the hero.
Wow, Cam, legend, man. I can't believe that. I actually had forgotten about fruit and Jell-O.
My whole childhood.
I think I'd actually forgotten Jell-O, but definitely forgot fruit and Jell-O.
What causes fluid in cavity during stims?
Oh, I'm gonna
Should a
make a
transfer
video on this.
Be done with that.
No, do not transfer. Your embryo is surfing and it's just gonna ride the wave right out of you. So isthmocele, the uterine niche defect of a C-section scar would be number 1. Hydrosalpinx would be number 2. Stenotic cervix would be number 3. Endometriosis would be number 4. Other than that, sometimes it's just there and we don't know why. We need a video on that. You and I gotta make a video on that.
I'll write it down in a second.
Yeah.
What do you think of Pepsid Claritin steroid for immune protocol?
So there's absolutely zero evidence for the value of Pepsid Claritin for, it's not an immune protocol, but for as add-ons or adjuncts to IVF. Zero. There is no evidence for the value of that. Absolutely none. There is no evidence. I've searched it up, down, backwards, forwards. This database, that there's nothing. There's just nothing out there. We are currently doing a randomized controlled trial of women getting pantoprazole for their embryo transfer to see if it will improve the success rates. So we'll know probably in 6 months or a year or something like that when we're done, but until that study is finished, we don't have an answer on pantoprazole. Now, I chose pantoprazole because there's evidence that it relaxes the uterus, but we don't actually know if it works or not. No one's ever studied it before. We're going to be the first, so we'll check it out.
People are surprised to see you on a Saturday. Like, oh, Dr. Victory on a Saturday.
I know, it's cool, eh? Yeah.
Yeah.
I mean, I'll take any opportunity to see T because I love the guy. He's a great friend. And we missed some questions last time because of the ladies that were on the show, who were great. So yeah, I wanted to have an opportunity to answer everybody, and we will be back again on Tuesday. After we have Jello, I guess, right? We're gonna
Now you have an obligation to make it.
I know.
You're gonna you should actually make it on the show.
Although one of my patients who brought the legendary brownies,
Oh, okay.
I might make those for us. I don't know.
Well, I'll be honest. I'll take a brownie over Jello every day.
Jello, yeah. Well, then maybe I'll make those because she gave me the recipe. They're phenomenal. They're the best brownies.
You actually got the recipe for that?
Oh, they were legend. Best brownies I've ever had. Like just next level brownie. Yeah. Yeah. Spectacular.
Amazing.
Spectacular.
Why is it not a good idea to take the pill and Lupron to prepare pre-stimulation? I'm 42 and have DOR, endo, adeno, and my consultant in London has recommended this to lower my LH and boost my FSH.
Lupron is going to suppress you, and prior to stimulation, it makes no sense at all. It's actually been shown to be detrimental, and birth control for someone with endo is useless and likely suppressive as well. And if you have endo, you probably have some degree of diminished ovarian reserve because they go hand in hand, which makes taking birth control even worse. So scientifically, there's absolutely no reason why you would do it. It just doesn't make sense. There's no benefit to suppression prior to stimulation. Zero. It's been proven to reduce your success rates. I forget the exact percent. I think it was 13% reduction in success. So it's useless. Don't suppress before you go into a IVF cycle. What you do need to do is do a frozen embryo transfer and suppress before your FE. To stim, you're just reducing the number of eggs that you get. I'm gonna sneeze.
Do it.
It's coming. Excuse me. Okay, sorry, go ahead.
Would you be concerned if day 3 embryos were developing quicker than normal, i.e. 10 to 12 cells on day 3?
There's morphokinetic data from time-lapse embryoscopy that shows that if your embryos develop too quickly, sometimes they're not good quality. But I don't believe all of that because there's like a billion different versions of the algorithm, so I don't think we know the answer to that yet.
Hello. What kind of IVF protocol do you use for unexplained infertility?
Standard stimulation protocol, so it depends on the patient's body mass index, their age, their ovarian reserve, all the different factors we consider. So I would customize it to all those different things and come up with a protocol for the patient. And then I would encourage them to do surgery before they do an embryo transfer because 44% of patients with unexplained infertility have endo. So then if they have endo, you need an endo protocol. If they don't, then you go ahead and do a normal embryo transfer.
Yeah. Can you explain the benefits of taking baby aspirin after a frozen transfer?
Not after, before. After is too late. Improved blood flow, reduced chances of preeclampsia, probably reduced chances of miscarriage, definitely reduced chances of preterm labor, thickens the lining a little bit better, prevents blood clots, so you're delivering more oxygen and sugar to the embryo. Well, that was not a happy moment. Anytime the phone goes smickety smack,
That's a real good smack.
Is it intact?
Yeah, we'll see.
Does it have a crack?
The front's good, that's the main thing.
Oh, all right. Yeah, you don't have a case for your phone.
You know, in my mind, I was part of Team No Case.
Uh-huh.
Team No Case are people that enjoy their phone.
Yeah, just no case.
Just No Case, because you know they when they sell you a phone,
Yeah.
it's so smooth, it's so
Right.
sexy, it's so nice. So I'm like, let me enjoy it.
Yeah.
However, I have kids, and they don't seem to be as mature as I am regarding how to hold the phone.
None of whom were here at the moment when you just plummeted your phone, by the way.
It's just what it is sometimes. I have a lot of clutter here in front of me. I'm very busy here.
We threw all 5 of Tarek's kids under the bus just now, none of whom were in any shape, way, or form anywhere near the event.
So it's my fault.
Lucy, you have some explaining to do when
So
you
it's my
get
fault.
home, buddy.
Alright. So maybe I should get a case.
I
But it ruins a lot. Like if you take your phone out of your case, you'll actually fall in love with your phone all over again.
I drop this thing at least twice a day.
Yeah, but you gotta
That's why
walk and talk in there.
I got OtterBox.
That's hardcore.
Man. Yeah,
That's hardcore.
like I got to be able to drop it out of a plane and have it survive.
It would.
Because the likelihood is.
I think it was.
It's well, I will admit that OtterBox is supposedly indestructible, but I have destroyed mine.
Oh really? There's no chip in it.
Even my OtterBox is toast. So yeah. No, I'm very good at dropping my phone. You know, I got my bag and I got my
there's
satchel,
a lot of things to carry.
my man purse and whatever else. So
Not sure if PCOS or high estrogen could cause the fluid in the cavity during stims too.
no,
Nope.
no, definitely no. Well, maybe high estrogen, although I've never heard of that before, but definitely not PCOS. No relationship with.
Oh,
Intriguing.
we have some commentary on the brownies here.
Oh yeah,
Yeah. Apparently,
yeah.
Paige says that I said I was sending brownies after delivery, and
Yeah.
C-section is next Friday, so brownies coming soon.
Oh hey, I'm not gonna complain about brownies. It's coming next week or coming soon.
Coming from what it looks like, coming Friday.
Sounds good. Okay, are you excited about our movie? Tarek and I are going to see Gladiator 2. I actually cheated and saw it last night, but
Big cheat, by the way.
I know I'm
Big
sorry.
cheat.
I'm innocent. The wife did it. I had no
Yeah, of
knowledge.
course.
Yeah.
You gotta respect that.
I know, but it was great. Yeah, yeah.
Now my wife is saying to herself, "Oh, so you're gonna go see Gladiator 2 without me?" I'm like, yeah, that's the way it works sometimes. Sometimes that's the way it works.
Super good movie. I'm very excited.
Is coasting during stims beneficial for PCOS?
I don't ever coast. Like once in a blue moon, I'll go one day with no drugs. Usually in an egg donor situation where their estrogen's getting really high, but the follicle size isn't high enough yet. And the reason is if you coast too long, the estrogen level will crash, and if they crash, you can't get the eggs out. They just don't come out. It's impossible. I don't know what the mechanism is behind that, but like you just can't get the eggs out. And I've seen that before several times, which is why I stopped coasting. The other reason you don't need to coast is, the reason to coast was to avoid ovarian hyperstimulation syndrome, which is easily avoided with an agonist trigger and a small amount of HCG. So why would you coast? Like it just doesn't make sense anymore. So I don't coast. I think coasting is silly. It's archaic. It's kind of dinosaur IVF medicine. We gotta watch Joy. You know what? We'll watch Joy and we should record us watching Joy.
2 cameras.
2 cameras for the facial. Oh yeah, you can have
We can
this
do it all
and
now.
click.
Oh, yeah.
That'll be. We'll do that. We can watch in the kitchen. We'll
Yeah.
eat our food.
Oh yeah.
Give some
it's a whole
food
thing.
commentary. Yeah, we'll watch
like
the
that.
movie and then we can clip it out and.
Yeah,
it'll be
have fun with it.
Yeah. I'll give you some running commentary on stuff I think I know about.
I'll give some running commentary on things I think I know about. I think this might be your last question for today.
Okay.
5:59. 7 transfers.
Whoa.
1 MMC on the first transfer.
1 miscarriage.
Miscarriage.
MMC.
We have a lab in January, immune testing with fertility next Monday, and hysteroscopy. Anything else? Can't PGTA as already frozen but need to collect again?
You could try, if they have images from a time-lapse embryoscope, you could try doing Life Whisperer AI for assessment of your embryos. It's not a guarantee, but it might give you some information. You should have a thrombophilia screen. You need vitamin assessment. You need sperm DNA fragmentation testing for your partner and oxidative or reductive stress in the seminal fluid. I wouldn't jump into hysteroscopy. I would want to do a 3D saline infusion sonohystogram, but that would be critical for you. Those would be the things I would start with. Thyroid assessment, it's the same as an RPL, RAF. Fertility for sure. Laparoscopy is very reasonable to rule out endo. Yeah, I would want to know what's going on, for sure. You got most of the stuff right.
6 o'clock.
6 o'clock. Okay. Lovely doing the Euro edition of Fertility Factor Fiction with you guys. We will be back on Tuesday, and I don't remember if we have a guest or not. I don't think we have a guest.
No, you have the following or the following?
Following, we have a guest.
Yeah.
The nutritionist, right? Yeah. So we have a nutritionist on the 3rd of December.
Yeah,
right?
whatever week that is.
Yeah, she's awesome. And then we have, I'll bring an article for this week, something cool. And then we might have more information by Tuesday, maybe about our program for the no medication immature egg retrieval. If not, I'm definitely hoping by the next week we will have a rollout, and we'll actually probably do a big promotion, advertising, social media, all that stuff. So let's all meet again on Tuesday. Fertility Factor Fiction. My thanks to Tarek, who came in on a Saturday for this. He's waving hello to everybody off camera. And my family for putting up with my crazy schedule, and the hospital who let me operate this morning at 7:30 in the morning to do an ectopic.
Always a blessing.
That was the most beautiful ectopic I've ever done.
Oh, really?
It was flawless. It was so nice. So yeah, you guys all have a wonderful evening. Enjoy the rest of your weekend, and we will see you next week on Fertility Factor Fiction. And if you are in Australia, you'll see me at 1:30 a.m. my time and 3:45 a.m. my time tonight.
Oh, no way.
I got 2 webinars, 1:30 in the morning and 3:30 in the morning.
I'm a huge fan. I just might not be awake.
Yeah, no, I don't think, I'm not expecting you to be awake, buddy. All right, guys, have a wonderful night. Go see Gladiator.